address you with a topic of entrusting juniors to take over your work. I chose the title a little bit also thinking of Doug and thinking of myself. At the end, I'm actually retired from I'm still hardworking, but I'll retired from my employment at University of Utrecht, University Medical Center. Doug is also very active still. I'll cite one of his publications of just last year. So I see that as an end of a period of a person that we say there's new generations that are going to take over our work. It could be in education, could be just in healthcare too. So training juniors to take over your work. And it is not something that is also specifically for healthcare. There's all sectors of society that you have juniors start doing things that you are doing, have to take over at some point of your work. Could be you personally, could also be a generation that follows your generation. Could be in crafts like this, could be in painting. Yesterday, I rehearsed this lecture in a different lecture hall and reminded of our lecture hall of Nicolas Tulp's anatomy lesson. If you've ever seen that, Rembrandt's one of the most Rembrandt's famous paintings reminded me of the entourage where I was yesterday. So I had a picture of Rembrandt here too. Actually has his pupils taking over his work. This is a little bit of a symbol of a very different area. Of course, it's this a bird with a youngster. And we use this as a symbol of our recent book about entrustable professional activities and entrusted decision-making that we just published a few months ago. But it symbolizes also a senior helping a junior to be autonomous by themselves, but still protecting them with their broad wings. Of course, we're not focusing on healthcare. Professionals need successors. And doctors, nurses, scholars, thinkers, managers, they won't live forever, and they need to make sure that there's a new generation. I have the privilege that every once in a while I take the oath for medical students when they finish the medical program, and Hippocrates already put in his oath the idea of that people would actually transfer the information to new generations. And then legacy of a person, not me, but maybe Doug Jones. There's a citation from a publication of Dick Krugman, who I was pleased to meet yesterday, wrote in 2007 about Doug Jones: extraordinary intelligence, integrity, perseverance, patience, collegiality, and congeniality. That is great, all that legacy, but it's not enough. Clinician educators have a primary mission to create new generations that can be trusted to take over their work and avoid the après nous le déluge attitude. That means we don't care about what happens after our task to graduate them is done. To avoid that attitude is also something that we should, as educators, think about. To take responsibility for training, for their performance after training. I'll come back to all those concepts. Now, working with EPAs, entrustable professional activities, offers the opportunity to address that if they are used in the intended way. And also come back to that expression. But before I do that, I have a question for you. Have you ever personally signed off for completion of a program or a rotation while you were not fully confident that the trainee, the learner, had met critical objectives? I have asked this question to many audiences. If you're interested, you might take your smartphone, take this QR code and see if you can give an answer to that. I did that yesterday too. And I have done that many, many times actually in the past few years. And I can give you an impression of what we generally feel. And funny enough, the outcome is usually the same. This is what it looks like. About 60% at least can remember one or more cases that they have signed up personally, signed up for completion of training, while they were not fully confident that the training had met critical objectives. And it's not unusual. It happens everywhere. This is all these 18 polls that I did in different audiences were in different countries and even different professionals. Here in this picture, I included the ones that I found just earlier this week in a dental conference. So just keep this in mind. I'll come back to that too. So now, working with entrustable professional activities, or EPAs, offers opportunities to address that idea of making sure that educators also think about their trainees after they complete their training, if used as intended. And here I'm quoting a quote from Doug Jones in an email that he sent to me, I think it was in 2015, about 10 years ago, saying that EPAs have now become a label du jour for almost everything. And I think it's one of the things that has always stuck with me, because if you can see my publications, very often it is trying to get the true message of what we mean with EPAs and entrustment decision-making across. And I can see examples where EPAs are being used in a way that I would not recommend. And it's a little bit aligning with that comment that Doug Jones did. And then I'm also, I had already referred to that publication of Dick Krugman, and that was also long ago. And Doug has been active, and I just wanted to show here in another quote that even a few months ago, he has been active and still thinking about EPAs, doing your work, how EPAs actually can improve the communication with learners. So let me go back to the more fundamental idea of, are you looking back or are you looking in the future as educators? Should assessment of clinical competence be retrospective or prospective? If we look retrospective, and I must say that most of education, secondary education, primary education, also most of higher education, the primary question for schools is, did the students do everything that we asked them to do? Did they pass their test? Did they do their assignments? And if they passed each of those, there's no reason not to give them a diploma. We don't really know what they will do in the future, or we don't even care what they will do in the future. Now in healthcare, we should think differently. We should think prospectively also. Prospectively is the question, answering the question, is the student ready to assume the expected future responsibilities? And that's a prospective way of thinking about education. And if you think of the word competent, if you look at the etymology of competent, or you look at it in the dictionary, you can see there's actually two meanings of it. One is ability, and we have been focused very much on that idea of does the student show ability? But if you look at it and think of an expression like a competent body, a body that is entitled and allowed to do things that others may not be able to do, then you're in the realm of the legal realm, or the realm of permission to do something. And maybe we should be caring more about that, thinking in a prospective direction, thinking of the future. Now, we've been there's a lot of development that had happened in medical education, and most people in the audience will recognize the expression of the Miller's pyramid. Miller's pyramid with 4 layers. And what we suggest, actually, the 4 layers could be extended with a 5th layer. The 4 layers are well known as a layer of the assessment of knowledge, applied knowledge, the integrated knowledge and skills, and the integration of knowledge, skills, and attitudes in the observed context. And Miller called that last layer the layer of does. And does really reflects looking at what learners do when you can observe them and you can actually evaluate whether they are doing well. But that's not exactly the same question as can they be trusted to do things in future healthcare? So we suggest actually that trust is thinking about their readiness to be entrusted with future tasks as the highest level that we are actually looking at if we observe learners and evaluate them. So that is all linked to the idea of competency-based education. Now, the essence of competency-based education in health professions is education aimed at a standard level of proficiency for all graduates. And if you're really serious about that, a standard level of proficiency, it really means that if they don't meet that standard level of proficiency in an estimated time that we found reasonable, and that's very often put into rules, then maybe we should think of training them even further until they meet that. So it is actually moving away from the idea of a fixed time and a variable outcome, because individuals happen to differ, actually moving then towards the idea of fixed outcome and maybe variable time if needed. So what is needed for CBME, for competency-based medical education, is a clear description of those standards of what is a good health professional, and to assess all trainees using those standards, and then have competence and not so much only just time in training as a primary reason to finalize that training. And hopefully, if we can really realize that, we can reduce those false positive decisions to complete training at the end of training. Those moments that you would say, I can't find a good reason. I feel my gut feeling says actually this student is not ready, but I don't have tools actually to stop them, so I'll sign them off. And I frankly hope they will not apply for a job in my hospital, or I actually hope that I will not recommend my own family members to be treated by that person. They're just not ready. So competency frameworks have been very popular. Competency frameworks they arose around the turn of the millennium. They have been used in many countries. They are accepted worldwide. There's a Canadian model that my country has used. But also, if you look at those competency frameworks and you read through them, and they become more and more detailed, actually, with new additions and new iterations of them. And they become too detailed and abstract and remote of practice. And many people find it difficult to use those frameworks for workplace-based assessment. And if you look at the literature, there's quite some criticism in the early part of the century, because of the connections with actual healthcare tasks remain rather unclear. And that was a reason to come up with the idea of entrustable professional activities. So to define that again, and most of you, of course, have heard of that word, but it may be good to reiterate that. It's a unit of professional practice. You could see that as a task or a bundle of tasks. It's a unit of the things that are expected for every professional to do, or a responsibility, you can call it, that may be fully entrusted to a trainee once they have demonstrated that they have the necessary competence to execute that activity unsupervised. There's many things in that definition that could still go more deeply in, but this is the basic definition. And the purpose to use EPAs is to operationalize competency-based education through a stepwise and safe engagement of trainees in clinical practice with progressive autonomy over time. So key features, again, and I'll come back to the idea that everybody uses that word for different things. It may be good to just rehearse what they actually are, EPAs. They are part of essential professional work in a given context, requiring knowledge, skills, and attitudes generally acquired through training. They lead to recognized output of professional labor. You must be able to say, well done or not. It's usually confined to qualified personnel only. You're not using an EPA for things that everybody would be allowed to do. And then it's executable in a time frame. It's really a task. a task that you could do on Tuesday morning, on Friday afternoon, or maybe next week, or it might be a longer task or a shorter task, but it has some feature of a beginning and an end when you can see the task is completed now. And then it's observable, measurable in their process. Did they do it in a good way and in their outcome, leading to a conclusion and reflecting one or more of the competencies to be acquired. Now, people sometimes mix up the idea of what is a competency, what is an EPA, and we had discussions this week, even yesterday, about what is a distinction. Maybe it's a simple figure might lead you to understand that. So the work that is being done in healthcare requires people to do that work. And what they need is a competency profile that fits with the work that needs to be done. But the work itself is not a competency. It is the work that must be done, and anybody could do it, but you need, that's not one person, but there could be more persons. But they need to have that profile that they are ready to do that and able to be fitted into that puzzle piece. And what they are not, of course, is the ability to do something. That would be a competency. That's a descriptor of a person. A person can be competent, can possess competencies. A person cannot possess an EPA. So the ability, it is not an ability to do something. It is not an assessment tool. It is not just even worse would be to call the form an EPA. And I hear that actually quite often. People would say, learners are complaining, but there's only a few days left this week, and I need 3 EPAs. So what they really mean is I need to be observed a few times. And the EPA is actually something that they are being trained for, that they can start doing. They take over work from someone. So what does it mean to be competent enough to take over work? If you look at how some people actually view education, I would say particularly outside of medicine, or when you would ask people what does education look like, they might think of it this way: there's a phase of education and there's a phase of practice, and you start on the bottom of being a novice and you end up being an expert. So here, this is your trajectory. And at the end of education, there's a licensing exam. And after that licensing exam, you can practice for the rest of your life. This is a dysfunctional view on education. It is the idea of that, and it happens, that even in medicine, that people would say you're not allowed to do anything until you have a license. And then suddenly after the license, we don't care about what you do. That's their phase of practice. So it is a dysfunctional. This is a much more functional view on education. I apologize a little bit for the layout that has been changed, but that's okay. This is actually much more useful curve to think about. People develop over time. They will probably develop until they retire. They get better and better. And they start doing things at early phases. And the idea of an educator is really to determine the moment when you think this person is now ready for unsupervised practice. And that doesn't mean you're qualifying that person to be the expert, but they're meeting the standards that are enough for them to start working unsupervised. And as we actually acknowledged a few times, actually even these days, that junior attendings usually have a difficult time because they have the responsibility, but they still feel they are developing. And while they are growing after training, they get more experience and do better and better. So that threshold level is that significant moment for an educator to say, now this person is now ready for practice. And that moment would be different for different individuals, and it would be different for different tasks, actually. So if you would operationalize that definition of the word competent, it would be when a professional activity is mastered at the threshold level that permits trust in that learner to act unsupervised. And that is a stage in a developmental continuum. If the continuum looks like this, you can superimpose different levels of development. Those are from a famous framework that has been used also in medicine very often, created by psychologists in the 1980s. And you could see from novice, advanced, competent, proficient, and expert that the word competent is right in the middle. It's not at the top. It is in the middle. And if we talk about competency-based education, here's a training period, there's that threshold, and there's that moment of readiness for unsupervised practice. And now you can apply that to one EPA, and that could look different for a different EPA, because a different EPA might be easier. At an earlier phase, you're at a higher level, and you might be qualified to do this unsupervised in an earlier moment. Or some other activity could be an activity that's been trained on a later stage only. And if you draw that line, the threshold line of competent, you can easily see that there's different moments. So why are we suggesting that learners should actually be trained in everything and be licensed to practice after training and meet all those criteria at the end of training? Why not make a developmental curriculum and say there is moments that you say, now you are qualified to do this work? I did a study with dermatologists a few years ago, and we actually looked at using EPAs. There were EPAs that a second-year dermatologist would really meet that level that was required, and it happened in most programs in the country. Actually, we checked that with a survey study. So it really means you can gradually qualify learners to work unsupervised, even if they are not at the end of their whole training period. So ready for unsupervised practice, and you can qualify people to do that. And funny enough, you could also add an EPA that they are being qualified, but if they never practice after training, they might even lose their skills, lose their qualification to be ready for unsupervised practice. If they picked it up again, they might need supervision, and they might lose our trust in them. Or here's something else: you could even add EPAs after training. So good example is that we're working with physician's assistants in the Netherlands who have a limited number of EPAs when they graduate, but they keep working in that clinical context. And their context, their hospital or their department is asking them to do things that they have not been trained in their training period. But they're now actually defining that as EPAs. They're being qualified, and the Association of Physician Assistants in the Netherlands will probably document that. They're busy with creating a system to document even EPAs after training. So if you take that idea of growth of competence and then superimpose something that you could call levels of supervision. We talked about supervised or unsupervised, but of course there's more detailed levels of supervision. And when you start training a person, you might say you're allowed to be in the healthcare space, in an operation room, or you can start with observing what we do. And then after that, you might be doing this activity with direct supervision. So direct supervision really means there is somebody in the room who observes you and take over if needed, or can provide you guidance while you're doing it. Indirect supervision would be a next level, which means that a learner does things and there's not a supervisor in that room present. So you're relying a little bit on a request for help. We call that reactive supervision. And then after that phase would be the phase of unsupervised practice. And there might still be the possibility to get some help if really needed, but you are actually have that past that threshold level that you say this person is basically ready to work unsupervised. And even if you're not in training, you could always probably call a colleague if you have a very unusual case. There might be ways to get some more help. Now, in this picture, it's a little bit like the same picture, but there's one difference. So we define training here as a period within which that decision has been made. We call that a summative decision for unsupervised practice. And it could be a formal decision made by for instance, a clinical competency committee, if you were talking about postgraduate training, you'd say, we actually allow this person to start doing this, and we hardly have to give any supervision. We trust them to do the work, but they are still in training. Now, here is where you as educators don't have that attitude anymore after Nulla Deluge. Because we can say, you're still in training, if something happens, we can still go back to you. So it is a phase, and it's also a principle of education. It is a little odd to say we're training people to do things we're never allowing to do things that they are supposed to be doing after training. So in the training phase, you should actually have a period you say, we're reflecting actually what you are going to do after we have finished training or provided a license or a diploma. So that is a phase that you could still actually really qualify and really know this student is graduating with the skills that we think that are needed. So this all leads to the idea of an individualized curriculum. The individualized curriculum means that in those levels, there's different moments for different persons and different EPAs that they meet that threshold level of readiness for unsupervised practice. And for a different learner, it could be different moments. And even if you have that learner say, well, we're making a plan with you. We have, this is a hypothetical program with only 4 EPAs, but you could say, why don't we create this and say, well, we expect you in the 2nd semester of the 3rd year that you will, for EPA, we expect that would be a reasonable moment for you to reach that level. If you don't reach that level at that time, it might be later. Or if we have monitored you well and observed you well, it might also be earlier. So you can adapt that idea. So the idea is that competency-based education is individualized training is really a principle. And that is because everyone is different. And we want to make sure that we graduate everyone meeting the expectations for practice, and not having people collectively considered to be ready after 4 years or 5 years or 6 years of training all at the same time. Now, if you make entrustment decisions and you see that as a concept, that is really linked to the idea of EPAs, you have to realize that there's a specific features of that concept. So trusting a person to do something for you that is important for you is always making yourself vulnerable to some extent. And it's trust in healthcare, trust in other things. And sometimes you'd say, well, there's 99% chance that everything will go right. There's only 1% chance that things will go wrong. So I would trust the person. I would trust a person, trust the airplane when I step in an airplane. And then I come home and I see an airplane crashed in Washington, D.C. And I just took a plane to Washington, D.C. Tomorrow I'll plane back home. But there's so much chance that I think it will go right that I would trust those people and the equipment. But it's also in persons, and it's also in healthcare, of course. What you're doing as an educator when you make that decision is you're deliberately willing to accept the risk that adverse events could happen. That's what I do when I step in that airplane. That's when you decide that this person is now ready to take over some of your work. They are ready to do that because you have observed them enough that you can say, we can now make that decision. It's a deliberate decision, and it's not stating that nothing wrong will happen, but you're accepting that risk. And of course, we have to realize that we will graduate graduates with activities that supervisors have not been able to observe. They're certified for things that nobody has maybe observed, and maybe they may not even have encountered. And of course, on a detailed level, every patient is different. So every time you see a patient, the learner would have to be able to do that. And when you make an entrustment decision, you're entrusting the individual to do the best things they can do to make sure that at the end of the encounter with a patient or whatever procedure is being done, it's done well. So the outcome is well. So it is not guaranteeing that the learner does exactly what you do, but is giving them a trust to do things with some space for autonomy too, and that they can do well. And what that actually means is you're also entrusting, we're estimating their adaptive competence to cope with unfamiliar situations. If you really think as an educator, can I trust this person? Then you want to make sure that they are flexible enough, agile, or whatever you call that they will, whatever happens, they will know what to do. And then trust is thus somewhat different than very much in education. We tend to think of, we can just average out all the observations that we have, all the tests that they took, all the everything, the grades they got for assignments, and we just average it out. And if it's good enough, we'll give them a diploma. Now, just think in healthcare. There's two learners, and this is a little bit of an odd scale. Goes from -10 to +10, and 0 would be like the acceptable level. And there's two learners, and the learner 1 has an average score of 2.1. Learner 2 has a lower average score of 1.9. And the question for you is then, who would you trust with your next patient of these two learners? It just gives a little bit of idea. So our educational thinking, we tend to think in psychometrics and numbers very often, but there may be more than numbers. And you can also think about this, of what factors determine entrustment decisions. Now, think of this decision. There is a preceptor standing next to a student and just considering, shall I leave the room? Shall I stay with the student? Can I trust the student to attend to this patient now? And if they can, you have something else to do. You could, you're considering that. And just realize that it's more than knowledge and skills and specific proficiency. And if you just analyze that one sentence, it sounds like a simple sentence. Can I trust this student now to attend to this patient? It's an ad hoc decision. We call that an ad hoc entrustment decision. You don't consciously think of that, but if you're leaving the room, you're actually implicitly entrusting the student with that task. So if you think of it, can I trust this student to attend to this patient now? And it is at least 5 factors, and we know that from the literature too. There's 5 factors that come into that equation. It is a supervisor, it's a task, it's a trainee, the context, and also the relationship that you have with the trainee. Supervisor will have their clinical experience, their clinical ability, their trust propensity, their supervisory experience. A task could be difficult, could be easy, there could be risks involved. The context could be, is there somebody else around on the board there who can keep an eye on the student, or what time of the day it is? We know that differences exist between decisions for the same situations in a night shift or during the day, or the needs for hands. And we have this big example of the COVID period where you needed all the hands, and you would make more easily entrustment decisions for healthcare workers who were maybe less trained to do the work because you just need their hands. And the like-mindedness and in their relationship or duration of acquaintance, or maybe even the interpersonal culture could make a difference. And of course, there are features of the individual. Now, we tend to think if they are very smart, they have good knowledge, and if they have the good skills to do things, that is our most important things, but there's more than that. We summarized the literature that actually looked into studies that were focused on the question, if you give a critical activity, say to a preceptor, you have to choose a student to do that. Which student would you choose, and why does it make a difference? What are the features of the student that you find important before you would say, go ahead and do it? So there's all sorts of different studies, about 10 of those studies we summarized, and we found 5 big factors. One of them is the specific skills and experience of an activity. But the next one is integrity. If they report back if something went wrong, and then you kind of feel you can trust them. If they never do that well, you would be more hesitant to trust them with a new activity. Or reliability is important. Do they show stable behavior over time? Are they well prepared for what they do? Are they conscientious look into the details? Are they accountable for what they do? Are they responsible to take responsibility? So in one word, do they show reliable behavior? And do they show sufficient humility? And humility would be, are they observing their own limitations? Are they actually willing to ask for help? Those are two even different things. Are they receptive to feedback from all sources? Could be you as a supervisor, could be their peers, could be interprofessional people, the nurses, or other people. Are they receptive to that feedback? So that is a sense of humility. And there's agency, of course. Do they show a level of self-confidence, proactive attitude towards their work, their team, patient safety and development? If you juggle these words around, there's an acronym that you can remember, because the first letters of that create the word A-rich. So we call that paper the ingredients of a rich entrustment decision. And if you think of trusting a person and making that decision, these factors are important. It's not just they pass their skills test, or they know how to communicate, or they have knowledge about the pathophysiology. It's also these things that are important in healthcare. Now, before we, I would like to continue with two specific concepts. And we call them nested EPAs and the idea of contribution to care. So the idea is when you develop over time, the task that you're asked to do could become broader and broader over time. If you start from a medical student in the first year until the end of residency, it's not useful to use the same words for the EPAs at the end of the training and the very beginning. So we call nested EPAs our small subtext. They're still EPAs in their own right, complying with the definition, but they become subsumed or nested within broader EPAs at a later stage of training. And then realize that one way to define an EPA is a contribution to healthcare. It is a contribution to healthcare. So as soon as a trainee delivers a contribution to healthcare that alleviates the supervisory effort, the EPA really comes to life. So if you say to a student, maybe the nurses could say in the first weeks of their first clerkship, why did you go to the patient and take their blood pressure? And we have observed that one or two times, and we understand you can do that well. So now we're not going to check anymore. So just give us we'll put it in the patient's record. That is for a medical student at could be a very first small EPA. And they are a contribution to healthcare. They alleviate the work of the nurse a little. So if you think of that nesting principle, think of for a junior medical student measuring the blood pressure and a senior medical student, of course, that would be subsumed in the whole idea of a complete physical and history as the broader EPA. But a junior resident, that would be even part of an EPA that you would call managing the uncomplicated patients. Or for a senior resident, it could be running the outpatient clinic. So this is specifically for very simple for medical students, but you could also apply it to surgery. A nested EPA that we're exploring at this moment in a project that we're doing at UCSF with the surgeons, using nested EPAs. For instance, the closure of the skin for an early, even an MS3 clerkship student could start doing that at some point, as what they suggested, and driving the camera for a sub-intern or an nested EPA for a junior resident, laparoscopic entry into the abdomen and the nested EPA for senior resident will actually, it's actually now becoming the full EPA, would be the full appendectomy. And this is another example also from undergraduate education, reflecting the way we use EPAs in my own school. That is, we would say for a clerkship in a specific domain, we would say, here's where you can be qualified for the general neurology history or the general neurology physical examination. And we're not signing you up for history and physical in general, but we can do that for our specialty, or we could do that in pediatrics. And only in a later year that becomes subsumed in at least in our school, in the general patient consultation. Now, go a little bit deeper on the idea of EPAs as a contribution to care. So even EPAs, even small and early, can alleviate the clinical work. And performing an EPA is not just an educational exercise then, because here you are starting to give back supervisory time, you could say. So at some point, you could say, we're training you to do things in healthcare. It's not just practicing anymore. It's not in a skills lab. It's not in a conference room, but it's actually in healthcare. So that is where EPAs come to life. And decreasing EPA limitations can be envisioned along two dimensions. So the entrustment supervision level and the scope of practice. So if you look at this, maybe I should start with this. So those are the 5 levels that we just explained, levels of supervision. If you go to specifically for medical students in undergraduate, you could adapt that scale. And Carrie Chin has done that with much more detailed steps. And let's take out the example of the 3rd level. The 3rd level is indirect supervision. To allow to practice under indirect supervision. But if you look more in detail, you could say, what does that really mean? So you could say the supervisor is immediately available and will check all the findings and decisions after the student has seen the patient. Or you could say, and that's at a higher level, the supervisor will still be immediately available, but they will only check key findings. Or even further would be that they only check findings on request of the student. So you can see that there are very detailed differences, but that's critical for the idea of contribution to care. And let's show that in a graphic this way. So the graphic shows what a supervisor does. And a supervisor, of course, is a clinician, has their own patients, is busy with patient care, and needs to carve out some time for supervision for a learner. And there's a baseline clinical effort that you could see here below that red line. Now, as soon as the student comes, and the student is at that stage of observation only, it will take you a little more time because you'll have your student in your consultation room, have to explain them before the patient comes, maybe afterwards. So it takes you a little more time. And now the next step is to act with direct supervision. You have to be there. You have to take over if needed. You have to instruct the student. So that takes actually quite some time. So it really does, it takes more of your supervisory time. But if the student does well, and you're further actually in that level, so you're still acting with indirect supervision, and or actually you're now acting with indirect supervision and everything is checked, the supervisor can actually do something different while the student is busy with the patient because they're not in the room, but they come back and check everything. It's still altogether probably a little more than just attending to that patient yourself. But now would you say the student acts with indirect supervision, there's only key checks, or here they're acting with only checks on requests. Here is where there's actually a pivotal moment, and you could see that this way. Where the star is where is the contribution to care actually starts. Here's where you start alleviating supervisory time and effort. And so here is where actually you're not thinking about that. Here's where the student is starting to take over your work. And if you look at the graphic, you can see that, of course, it increases at a certain moment, but then it decreases again. And I had a discussion with a German group 2 years ago. They were thinking of introducing EPAs in their practical year. They have a practical year after medical school before the students go to residency. And there were some people enthusiastic to do that, to give that more structure. There were others who were very resistant to that idea. And now, when I had a conversation with them, the ones with a good experience, they said, if you are willing to train that student well in the second half of that practical year, they can start to help alleviate your workforce. And that is actually your responsibility too. So as an example, how others start using that idea of how the student can start taking over some of that work. And then you could look at when can you do that? You could look at the scope of practice on the left side in this slide is actually the idea of nested EPAs or small nested EPAs, and become gradually broader and finally into that full EPA. And there's also those levels of supervision or level of entrustment supervision, from observe others to supervise juniors. And of course, these are the moments that students really have taken over all of your work. They can do that. They can act completely unsupervised for the full EPA. They can even start being a supervisor for junior learners. So they clearly take over. But if you think of it, there are earlier stages that they can start doing that. All those stages with a star is where the student can start taking over your work. So, and then if you look at this same graphic and you superimpose those ideas of how much autonomy does a learner have for no autonomy, building autonomy over time until they are ready for that threshold level. And then after that level, there could be still supported autonomy. They can still rely on some help if they need help. But that is a period of time that is important. And it also leads to the idea of really knowing that the student is ready at graduation. So in conclusion, training juniors to take over your work through entrustment is not essentially just an assessment idea. It brings three parties into the equation. It's the student, the patient, and the educator. And I would say trust is the core currency to make healthcare and education for healthcare a true human endeavor. That's nothing that a machine can do. That is the relationship you have with your supervisor and your supervisory team. And the whole idea of them trusting you and the conditions for trust is so important. And I may conclude maybe with the idea that at times when trust between numerous parties, I would say in society, is so much challenged by forces that are unprecedented in recent history. And I don't have to give examples. You probably understand what I mean. And I would say, let's keep the currency alive, at least in our own everyday work of healthcare education, health professions education. So thank you for inviting me, and thank you for listening. And congratulations again for Doug Jones for his remarkable career, and also for
We have one further announcement.
Are you?
Yep.
Somebody changed this. I didn't write this. I actually said title expicer. So do I have to make that announcement now? Because I'm flabbergasted, actually.
So we as part of this, we established an annual award starting this year for a junior faculty educator. And as you can see, Julia Tanabe is the first recipient of that. Julia, I'll just read what she does. She's a primary care pediatrician, but she is the director of the primary care pathway. She is the director of the primary care curriculum. She is the education director for general pediatrics. Second to most importantly, she was the 2024 Gary Way Award winner. And she has added one more title to her portfolio. As of yesterday, she is a new mother. So she is not here with us today. But as part of this award, she will be delivering grand rounds sometime in the next year on an education topic. So we'll celebrate her at that point. So congratulations to Julia.
Okay, so I need an explanation, because my impression was that Ty Loxpeiser was actually the first endowed chair linked to Doug Jones. Isn't that not true then?
That is true. Yep.
Okay.
Ty has a different, much higher leadership role.
Okay.
Than Julia. Yep.
But I wanted just to conclude showing you that how younger generations are taking over from senior generations. Thank you very much for your attention.
So questions for Olle?
Good.
A fantastic lecture and of course fascinating concepts. I wanted to ask you, I mean, your vision sort of looks into the trainee and its evolution, assuming that we all as educators have the same way or homogeneous way of sort of training people. Does the educator also have issues, or does it have to have certain characteristics that have to evolve in order to be able to conduct that entrustable process?
Mm-hmm.
In a way, for example, if you find an educator that is not as humble, or perhaps has lost its drive, does that transform the educational process into a different matter?
Yeah, so I think your question is about how do we get faculty who are so different actually understand the concept, and I think it starts with expressing the vision, and usually my experience is explaining this, and I used more details than I did before. So there are some new things actually in this lecture, but my experience so far is that people they really understand. When I have audiences, I usually like live audiences much more, because I can see that people are nodding, and if I see you nodding, then I feel that, so people start understanding. There might be people who don't understand, and I have to add to that. So maybe if I talk about this for half an hour, it sounds logical. When you put that into practice, many questions come up. So it is useful to really explore that more in depth. I try to do that. We actually, I can tell you that we just published a whole textbook just a few months ago on the concept and everything that relates to that, from the theoretical backgrounds until the applications in nursing in Singapore, for instance, that we also. But then, so there is. I wouldn't say that everybody would understand it directly. My experience, however, is that people usually do not deny the idea or those ideas, actually. So they wouldn't say this is the wrong idea. So even if they are not trained themselves in this way, they still start understanding it. And I think entrusting a learner with the care of or trusting a learner with the care of patients has been part of medical education for centuries, always. And there's a picture that I sometimes show from the Greek mythology, where Apollo actually gives his son in the care of Chiron, which a mythological figure who trains that son, and that son happens to be Asclepius, who has been the god of healthcare, at the medicine. So to show that even there you could link that to concept of entrusting a person to do something that's very important for you, actually raising your own son. But in patient care, most people really understand it well, even if you're not trained in that direction.
Thank you so much. It was fantastic. Can you talk
Can you speak up in the microphone?
Yeah. Can you talk a little bit about how this concept might fit in and complement something that I don't think we do a very good job of, and that is succession planning for people rising into academic careers where there's a natural transition of succession planning where we do entrust younger people in the hierarchy so that they have hopes of taking on leadership roles and advancement roles. And how do we help build that in so that it's not considered dramatic when it happens, but it's an expected part of kind of the developmental milestone of our careers overall?
Yeah, let me start by saying that using this title for this talk, taking over your work, sounds very individual. But basically what we're doing is we're training generations, and we're training generations to take over from us. Succession planning has so many different parts of that. And so we talked with other people about the I think it was pediatric rheumatology. Is there enough interest in that? People were worried that not enough students would actually choose that direction for their specialty. So that's an issue of succession planning that is very different. So the focus here is really, I would say, on the educational psychology or educational research for how the educational concept of succession. And there are many things in succession planning that you do, but maybe the big lesson I would suggest from this is that you are, as an educator, the one who is actually educating for your own profession, and that makes also health professions education pretty unique. If you think of many other studies or in secondary education, teachers are not training their students to take over the teaching job. They're training them to be whatever they might not even care what they start doing after school. But here, I think we can more deeply think of that is why the educating physicians should be done by physicians, and we can have help by other people. They can support you. But I think it's almost like a Hippocratic obligation. I say that to students too. In my school, we have a teaching rotations that is mandatory for all students. It's a 2-week experience in teaching. And I usually ask them, is this logical for medical education to have a teaching rotation? And funny enough, they usually confirm that they understand that. It is because, and they would say, yes, teaching is a natural part of being a physician. And we realize that we are encountering, when we're residents, we'll have medical students in our wards, and we'll have to be ready to actually help them too. So it is inherent in, I would say, a profession. Actually, if you use the sociological definition of a profession, it's a profession that confines their own domain and knowledge and skills, and is also responsible for their succession too.
I can speak loud enough.
I'm going to get there.
In America, there's one other layer, the private outside the academic world and the academic world, public education. In the private world, oftentimes we are asked to help trainees, take it to the next independent level so they're ready for the real world. But it's basically an unpaid task. You're relying on people's goodness of will, desire to enhance the profession, but the academic centers are relying on that to, for the outside world to help these young people make the transition in an unpaid fashion. Comment.
Yeah, I think your question is broader, and I can give several sorts of answers. One of the answers is that people say, well, I'm not paid for this, and I'm not going to do that. It takes me time, there's no return on this investment for me. That resonates with things that I hear all the time. When we're talking about competency-based education in a South African context, I work a lot with the people in other countries. They would say, we can't do this. We are so low resourced. We don't have time to to observe learners. We can't do that. When I talk with people in the most affluent countries, they would say, we're so busy, we don't have time to do this. So it is also what is the vision of what healthcare actually really means? So I would, how would I express that? It is also priority, and one of the reasons why I find that also Hippocratic also important is that people start realizing I'm a physician, but that's not only doing radiological interventional procedures. That is not enough. It is a little, I would say, with another French expression, noblesse oblige, you are in a position that you can do this, and that implies also that you have some responsibility for succession, not for you only personally, but actually for the community. So what worries me personally, or actually you could look at what trends are happening, it's also happening in my country, is that healthcare is commercialized much and much more. I try to avoid political statements, but I truly think that there are some things that societies and governments in society are core pillars of their responsibility. And one is healthcare, one is education. Security is a third one too, but healthcare and education are government, and things go wrong when you would say, this is not my responsibility, let the market do this. We'll find private investors who invest in healthcare. They're not interested in education. I think we're going in the wrong direction. And if I frankly look at, I don't want to be too critical, but if you look at the cost of healthcare and the quality of healthcare in the United States, it could be much better. And one of the reasons is I think there's a direction of healthcare that is, I would say, steered by commercial purposes only. Different sectors in the healthcare it's including the provision of pharmacy and other things. So, but every country is different, and I wouldn't say my country is better because we have problems too, and some other things. But I think as professionals, as a professional community, I feel strongly that it's an obligation for the community to think, how will we train our next generation of physicians? And carve out time to do that also. Take responsibility. And again, so the example that I showed here in the slides, if you would be in a private situation and say, well, you're training a person to start taking over your work, you might even think that at some point it gives some sort of return of your investment too.
All right, I think we're going to have to cut things off. There's a little bit of food out there if people want to chat and say hello to Doug and Olle. Again, Olle, thanks so much for a really wonderful presentation.